Hello to all the surgeons, anesthesiologists, critical care specialists, and clinical researchers. I would like to express my gratitude for your boundless dedication to the care and surgery of transplant patients. Today, we will discuss the immunosuppressive drugs used for organ transplant patients. As clinical practitioners at the very forefront of this demanding field, you already know that the precise balance we strike in the perioperative and postoperative phases essentially dictates the rest of our patients' lives. This explainer is designed as a rigorous international academic refresher. We're going to synthesize decades of literature to help optimize our pharmacological strategies, diving deep into the data that shapes our daily clinical decisions. Our agenda today covers 6 key areas: the plateau of success, the biological battlefield, organ-specific induction evidence, maintenance regimens and toxicity, the peculiarities of lung transplantation, and finally, the future of personalized tolerance. Let's get right into it. Section 1. The Plateau of Success, Historical Context, and Current Limitations. To really understand where we're heading, we have to look back at how our pharmacological arsenal has evolved, and why our current standard of care is, quite frankly, hitting a ceiling. Drawing on data from Lee in 2020 and Panicle in 2022, let's trace this journey. Back in the 1960s, our predecessors were basically fighting a losing battle with just corticosteroids and azathioprine. But then the landscape completely shifted. In 1983, the introduction of the calcineurin inhibitor, cyclosporine, was a massive game changer. Then came tacrolimus in 1994, which truly inaugurated the modern era of transplantation. The late 90s and 2000s brought us targeted biologics like Basiliximab and ATG in 1998, followed by the mTOR inhibitors, sirolimus, in 1999 and everolimus in 2010. This rapid expansion led to our current standard maintenance therapies, typically a combination of a CNI, an antimetabolite, and perhaps a steroid. And yes, short-term survival absolutely skyrocketed. But as you all see in your follow-up clinics, the story definitely doesn't end there. Despite all these pharmaceutical triumphs, long-term survival has completely plateaued. Recent data, particularly from Panicle and colleagues, highlights a very sobering reality. Late mortalities are predominantly driven by our own drug toxicities, not acute rejection. Look at the numbers. Rejection accounts for a mere 1.7% of late mortality. Meanwhile, malignancies make up 16.4%, and opportunistic infections sit at 10.5%. We're seeing premature transplant failure and death in patients with a perfectly functioning graft simply due to chronic kidney disease, metabolic syndrome, and the sheer crushing burden of chronic immunosuppression. We aren't just fighting rejection anymore. We're fighting the long-term consequences of our own life-saving therapies. Section 2. The Biological Battlefield, Mechanisms of Immunosuppression. Overcoming these toxicities requires a precise molecular understanding of the T-cell activation cascade. We need to know exactly where our drugs intervene so we can break the cycle. The classic 3-signal model of T-cell activation elegantly maps out our intervention points. As a quick refresher, signal 1 is the T-cell receptor engagement with the antigen-presenting cell's major histocompatibility complex. Signal 2 is the co-stimulatory pathway, most notably CD28 binding to CD80 or 86, and signal 3 is the cytokine-driven proliferation phase, primarily fueled by interleukin-2. Calcineurin inhibitors, like tacrolimus and cyclosporine, work by blocking NF-κ activation, which essentially shuts down IL-2 transcription. Meanwhile, mTOR inhibitors like everolimus step in later. They halt the subsequent IL-2-driven proliferation by arresting the cell cycle. Antimetabolates disrupt DNA synthesis, and co-stimulation blockers like belatacept intercept signal 2 entirely. It's a beautifully complex yet targetable cascade. By systematically classifying these agents by their distinct mechanisms, as heavily detailed by Lee, Kahn, and Khayyam, we can design regimens that maximize synergistic efficacy while sparing individual organ toxicity. Notice the functional divisions. We have our depleting versus non-depleting induction agents like ATG versus Basiliximab. We have the purine synthesis blockers like MMF, and we have emerging monoclonal antibodies like Basiliximab targeting the CD40 pathway. Understanding these classifications isn't just academic, it's fundamental to personalizing our approach. We have to shift from this outdated model of blanket immune suppression toward highly targeted, patient-specific immunological modulation. Section 3. Organ-specific induction evidence, liver transplants. Let's examine the clinical evidence for induction therapy, starting with the liver, an organ with fascinating, unique tolerogenic properties, where steroid-sparing strategies have garnered intense focus. The clinical data here is incredibly compelling, though it requires some careful critical interpretation. Let's look at the Cochrane 2020 Network Meta-Analysis by Best and colleagues. This was massive, 25 RCTs encompassing over 3,200 patients. It suggests that Basiliximab induction dramatically reduces all-cause mortality with a hazard ratio of 0.53 and graft failure at 0.44 compared to glucocorticoids. But, and this is a big but, we must note this is considered low-certainty evidence with a high risk of bias across many of those trials. Conversely, the meta-analysis by Jung and colleagues, looking at 11 RCTs and nearly 1,700 patients, provides crucial nuance. They actually found no statistically significant difference in acute rejection rates between Basiliximab and steroids, with a relative risk of 0.85 and a p-value of 0.06. However, Basiliximab dramatically reduced the risks of cytomegalovirus by over 50%, diabetes by nearly 60%, and hypertension. They even saw a reduction in HCV recurrence. What does this tell us? In liver transplantation, induction is really about achieving immunological safety while aggressively cutting metabolic and infectious morbidity. Though, as a quick caveat, trial sequential analysis indicates the required information size for definitive conclusions on acute rejection just hasn't been met yet. Section 4. Organ-specific induction evidence, kidney and SPK transplants. The immunological demands shift considerably when we transition to kidney and simultaneous pancreas-kidney, or SPK transplants. These allografts are highly immunogenic. In these highly immunogenic scenarios, Kamaraja's 2021 network meta-analysis of SPK transplants, which looked at 7 RCTs in over 500 patients, reveals a fascinating dynamic. The data indicates that while alemtuzumab, which is a potent CD52 depleting agent, is absolutely superior for preventing acute rejection episodes, it's actually the IL-2 receptor antagonists that ultimately yield the best long-term patient, kidney, and pancreas graft survival. Specifically, daclazumab was highlighted in the data, but given its market withdrawal, Basiliximab stands as our practical, safe, non-depleting alternative. Echoing the Cochrane 2014 findings, the crucial takeaway here is that while heavy cellular depletion stops early rejection cold, a milder blockade with Basiliximab often translates to better long-term survival. And that is highly likely due to a much lower burden of severe opportunistic infections down the road. Section 5. Maintenance regimens and managing toxicity. As we transition our patients from induction to maintenance, the clinical dilemma becomes a daily, high-stakes balancing act, preventing allograft rejection versus the pervasive, progressive threat of CNI-induced nephrotoxicity. Pivotal trial data illustrates this struggle beautifully. When we look at data synthesized by Khan and Qayyum, evaluating current standards alongside novel pathways, the tension is obvious. Regimens anchoring on tacrolimus with mycophenolate consistently preserve early renal function and keep biopsy-proven acute rejection at bay. It's the gold standard for a reason. However, alternative CNI-sparing strategies using mTOR inhibitors or novel co-stimulation blockades like belatacept or the CD40-targeting Basilumab are absolutely critical areas of research. The ultimate goal here is to decouple our potent immunosuppression from the inevitable slow-motion renal decline caused by prolonged tacrolimus or cyclosporin exposure. Let's delve into the specific numbers from landmark studies like Mendez 2005 and Guerra 2011 to really understand this trade-off. The Mendez multicenter RCT with 361 patients clearly showed that tacrolimus plus MMF was superior to tacrolimus plus sirolimus at 1 year for both graft survival and renal function. But Guerra's 8-year follow-up data is particularly sobering. It demonstrates that standard tacrolimus and MMF maintain the lowest acute rejection rates, sitting at an impressive 12%. But when they converted patients to mTOR inhibitor regimens like tacrolimus plus sirolimus, acute rejection rates skyrocketed to 30%. Cyclosporin plus sirolimus wasn't much better at 28%. Furthermore, these mTOR inhibitor conversions often suffer from significantly higher drug discontinuation rates. Why? Because of side effects like profound dyslipidemia, viral infections, stomatitis, and proteinuria. So while mTOR inhibitors theoretically protect the kidneys by sparing them from CNIs, the clinical reality is a very complex trade-off of heightened rejection risk and distinct challenging metabolic penalties. However, let's move to a specific cohort where mTOR inhibitors truly shine: patients receiving a liver transplant for hepatocellular carcinoma. According to a phenomenal 2022 systematic review and meta-analysis by Jan and colleagues encompassing 17 studies, sirolimus or everolimus-based regimens provide a profound advantage here. In RCTs, they saw overall survival relative risks improving year over year, from 1.04 at year 1 to 1.13 by year 5. They directly inhibit tumor angiogenesis via VEGF inhibition and block cellular proliferation. The clinical translation is massive: improved overall survival, significantly improved recurrence-free survival, and a 25% reduction in renal toxicity with a relative risk of 0.75. For our HCC patients, mTOR inhibitors are doing double duty. They are not just immunosuppressants, they are active, targeted anti-neoplastic agents. Beyond direct organ toxicity, we must meticulously navigate metabolic penalties. As outlined by Kotha's 2021 meta-analysis, the choice of maintenance therapy literally dictates the patient's cardiovascular future. Tacrolimus carries a notoriously high risk for post-transplant diabetes mellitus, but generally lower risks for lipids and blood pressure. Cyclosporin, conversely, is moderately diabetogenic, but highly detrimental to lipid profiles, causing severe hypertension and hyperuricemia. And of course, corticosteroids are universally deleterious across almost all these metabolic parameters. Therefore, minimizing steroids early and carefully selecting between tacrolimus and cyclosporine based on the patient's pre-existing cardiovascular risk factors isn't just an afterthought. It's just as vital as preventing rejection itself. This constant balancing act is best described by the concept from Roberts and Fishman, the net state of immunosuppression. It is not merely about calculating a milligram per kilogram drug dosage. It is a dynamic, shifting equilibrium. We must constantly titrate our pharmacological intensity against the patient's intrinsic immunity and, crucially, against rigorous viral monitoring. Reactivation of cytomegalovirus, BK polyomavirus, and Epstein-Barr virus. These are our canaries in the coal mine. They tell us when our net state has tipped too far, threatening those catastrophic, opportunistic infections that, as we saw right at the beginning, are a primary driver of late mortality. Section 6. The peculiarities of lung transplantation. We must also recognize that not all organs are immunologically equal. As we pivot to thoracic surgery, the lung presents an exceptionally hostile allograft environment. As detailed by Atkinson and Sharma in 2023, lung transplants suffer significantly lower long-term survival rates compared to abdominal organs. Think about it. The allograft is constantly exposed to the external environment with every breath, driving aggressive chronic rejection, which manifests as chronic lung allograft dysfunction, or CLAD, encompassing both bronchiolitis obliterans syndrome and restrictive allograft syndrome. Because of this extreme immunogenicity, there is a heavy reliance on potent upfront induction therapy, with over 80% of lung patients receiving it compared to a fraction of liver patients. Furthermore, there's a unique surgical peculiarity. We must strictly delay the initiation of tissue-sparing mTOR inhibitors for at least 3 months post-transplant. Why? Because their powerful anti-proliferative effects drastically impair wound healing, increasing the risk of fatal airway anastomotic dehiscence. It's a completely different rulebook. Section 7. The future of personalized tolerance. As we confront the very real limitations of our current standard of care across all these organs, the field is rapidly advancing. We are moving toward customized immunological modulation rather than brute force suppression. The future, as synthesized beautifully by Yassari in 2024, lies in abandoning this blanket suppression entirely. We are moving towards exploiting natural physiological pathways. For instance, intentionally inducing T-cell exhaustion via the tox transcription factor. We are developing next-generation precision co-stimulation blockades and highly targeted donor-specific antibody suppression. Furthermore, the horizon includes cellular therapies, deploying the patient's own regulatory T and B cells and manipulating tolerogenic dendritic cells to essentially teach the host immune system to actively accept the graft. The goal is no longer just holding the immune system hostage. It is achieving true active operational tolerance. In summary, this table encapsulates our current, evidence-based paradigms across the specialties. For the liver, Basiliximab induction to spare steroids, followed by low-dose CNI, reserving those mTOR inhibitors primarily for our HCC patients. For kidney and SPK, risk-stratified induction, alemtuzumab for high immunologic risk, Basiliximab for standard risk, maintained on tacrolimus and MMF. And for the lung, heavy upfront induction with a delayed introduction of proliferation inhibitors. This brilliantly illustrates that induction and maintenance must be meticulously tailored, not just to the specific organ, but to the patient's unique comorbidities, viral status, and their ultimate risk of chronic toxicity. As you leave this explainer and return to your clinical duties, to the ICU and the operating theater, I want to leave you with a final provocative thought. We have spent the last 60 years refining biological toxins to suppress the immune system. But as we begin to master the molecular pathways of T-cell exhaustion and regulatory cell networks, how close are we to achieving the ultimate holy grail for patients? True, drug-free operational tolerance. Thank you for your time, your rigorous attention to the data, and most importantly, your relentless dedication to the lives of your transplant patients. Let's keep pushing the boundaries of what is possible.